Hey everybody, good afternoon. I'm Laura Cook. My title is Regional Supervisor at Youth Villages. I oversee uh, MST, our Intercept program, and also foster care. I work out of the Cookeville, Tennessee area, and I've been with Youth Villages for, I guess, about 13 years now. And so just thank you for being present and attending the training.
And I am Jenny Roque Pichardo. I am the program expert for MST for the entire state of Tennessee. So I cover all of our Youth Villages MST teams. I've also been with Youth Villages for about 13 years, and I've been in the MST program for coming up on 8 years this year. So we're going to briefly go over what MST is, looking at an overview, the kids we work with, how we implement the model, and then how do we evaluate our outcomes. So MST is intensive in-home treatment that's designed to work with youth who present with antisocial and delinquent behaviors. But even though the youth is our identified client, our work is around empowering the caregivers or other adults that may be in the youth's life to be the change agent and change the environment so that the behaviors also change. So when we think about the client, we're thinking about the 5 systems that the youth belongs to: the individual system, the family system, the peer system, school, and community. And the reason that we're looking at that whole ecology and the 5 systems is because the research shows that there are factors in different dimensions that drive delinquency and substance use within those 5 systems. So by targeting all of those, we can see more sustainable change in a youth's referral behaviors. MST is not just in Tennessee. It is a treatment model for youth in the juvenile justice system or with delinquent behaviors in most of the states in the US, but also in 15 countries around the world. And so that shows that the treatment model itself can be generalized to different populations, different areas, all kinds of different families or systems. Now, Laura's going to talk a little bit about who we work with specifically in Tennessee and what areas our teams cover.
Okay, so this does say that this is offered statewide, which is not exactly true. There are a couple of regions that we do not provide MST in. Currently, that would be the Upper Cumberland and South Central regions. Um, I can speak specifically to the Upper Cumberland region. We do have a history. We used to have MST available in this area, but our contract with MST Clinical Services does require us to have a team of 2 full-time therapists, and they each must carry a caseload of 4 to 5 cases. So over time, that number started dwindling, and so we had to make some changes, and unfortunately, we were not able to continue that program due to not being able to keep 2 full-time therapists like at a full capacity. So in the Upper Cumberland region specifically, we do still provide Intercept, which is intensive in-home services, and we can target most all of the referral issues and problem behaviors that we typically see. Um, I will say too, just we are more rural, so I think that might also impact the number of cases that we see in this particular region, in comparison to more urban areas. So I think that's a factor as well. But we are active, like as far as middle goes, I specifically work in Davidson and surrounding areas and also Montgomery. So, if you have a referral, please send it in. We'll provide that information later, and we will assess and try to make MST happen. If there's any kind of barriers, we try to overcome those by maybe referring to a different program. We will work with you and talk with you through that just to make sure that that child and family's needs are met.
And I would just add to that, regardless of where you may work in the state, if you have a youth who needs services, send a referral, because let's say there's a bench in South Central that maybe need it. It would show the need to have a team in that area and to serve those youth. So please send referrals if there are kids who need services. And of course, we're going to try to accommodate what will meet their needs. So then talking a little bit about who do we work with and what are our inclusionary and exclusionary factors. In Tennessee, we work with kids between the ages of 12 and 18. If a youth is already 18, there are some additional criteria. The youth has to consent to treatment, but all of the other factors also still have to be in place. They still have to live with caregivers. The caregivers still need to participate in services. If at any point they were living independently, then they would not be appropriate for MST. We work with kids who are involved in the juvenile justice system, but MST can work with kids who haven't quite made it to that point. So they may be presented with behaviors that puts them on the path to juvenile justice, but they haven't actually been charged or gone to court. So any youth with those antisocial delinquent behaviors that could include substance use, physical aggression, theft or stealing, running away, truancy, poor academic, those are all the common referral behaviors that we're going to work with. What excludes a youth from MST is if the youth lives independently and there are not identified caregivers for that youth. It could be exclusionary if the youth has sexual offending behaviors, and that is the only referral behavior. But again, if you have a youth with sexual offending behaviors that need services, please send the referral, because we fully assess every youth when we get a referral to see if they meet criteria or not. And they may have other behaviors in conjunction with that would include them for MST. Youth with any type of developmental delay or moderate to severe autism could be excluded based on their functioning level. But again, send the referral and let us assess to determine if it would be appropriate or not. And then if youth are actively suicidal, homicidal, or experiencing psychosis, that could exclude them until they are stabilized. That doesn't mean if a youth has a history of these behaviors, we would exclude them. But if in the moment they're saying, I am actively suicidal, I want to kill myself right now, that's when we would help refer to get them stabilized, so that once they're stabilized, then we could admit MST. Same for homicidal or psychosis. And then it could be exclusionary for youth whose behaviors are driven primarily by psychiatric problems. So if the only concern is that a youth is significantly depressed and all of the behaviors are internalized, that's someone who may not be appropriate for MST. But one example, when we think about psychiatric problems, may be a youth who has a diagnosis of schizophrenia or some type of psychosis, but they are taking their medication, they're stabilized, and the behaviors are driven by other factors. They're not driven by that. We've worked with a lot of kids who have had a diagnosis of schizophrenia, but are stealing cars or getting guns or using drugs. And they were appropriate just based on the referral behaviors and being psychiatrically stabilized through medication. So again, if there's any questions, please just send the referral. We can assess and then we could staff it after if it's appropriate or not. And if at any point you all have questions, please feel free to put it in the chat or come off if there's any questions about who we can work with or who we can't work with. And then looking at how do we provide MST? MST is more cost effective than a lot of other treatments like residential treatment or out of home placement, but also the research supports that it is effective to address the concerns that these youth present with. So as Laura mentioned earlier, an MST team will have one supervisor and then anywhere between 2 and 4 therapists on the team. Each therapist is going to have a caseload of 4 to 6 families. So it's a small caseload so that we're able to provide that intensive service. The average length of treatment is going to be between 3 to 5 months. MST is intensive, but it is a short-term treatment program. Cases could be extended up until a 6 month, but that is more rare and it's based on clinical need and would be determined if at that point there were still additional goals that needed to be worked on. As a part of the MST program, we are available and on call 24 hours a day, 7 days a week. So if a family has a crisis in the middle of the night, if a youth is having behaviors on a weekend, holiday, the family can contact us. We're available to provide support over the phone or in person if needed. And all of the work that we do is in the home or maybe at the school, collaborating with the family in the school, or in the community, collaborating within that system. As a part of our treatment model, we pull from different research-based treatment programs that you could see here, looking at behavioral therapy, parent management, some CBT, different family therapies. And then although we do not prescribe medication through MST, we would collaborate with a med provider if the youth is on medication. As far as our outcomes, we look at both objective and subjective measures. With our 3 main outcomes at the time of discharge, is the youth living at home? Are they in school or working? And have they been rearrested during the time that we're in the home? This data here is across MST programs worldwide, but of all the MST programs and all the teams, this is the data on the effectiveness of MST based on those 3 ultimate outcomes. I saw that question about the average response time. So they should be able to reach someone immediately by phone. Each of our teams manage their own on-call. So if a family calls, it's going to go directly to an MST therapist. So there should not be any gap or delay. If for some reason that therapist was on another call, there may be a couple minutes before we could call the family back, but it's going to be immediate. And if it's something where we need to go in person, all of our therapists have to be within a certain area of a family where 90 minutes is the furthest we can work. So the longest response time would be a little over an hour, but typically where our families are located and where our therapists are located is much quicker. And so it could be anywhere between 15 minutes if they live really close by to maybe an hour, depending on where that family lives. If a family lives more rural, it may take a little longer just with travel time, but it should be within about an hour max if we need to go out in person. And then some of the more subjective measures that we look at are around at the time of discharge, have the caregivers improve their skills to handle problems when they come up in the future. We know most of the youth we work with may have behaviors long term. It's not that the behaviors just stop, but it's do the caregivers have the ability to manage that when it happens? But we also look at family relationships, support networks, how the youth is doing academically or at their job, and if the youth is involved with more positive peers or other pro-social activities. And all of those, does that mean there's sustainable change for that youth and family? Looking at outcomes, there's been several research studies on MST that show the longevity of sustainable change. So in research studies following kids 14 years after discharge and up to 22 years after discharge, it shows that there are positive outcomes long term for those youth in a lot of different areas compared to youth with similar behaviors that either didn't receive treatment or had a different type of treatment. So the sustainable change that happens within that period we work carries on into their adulthood. All right. So that wraps up our portion of presented MST, but does anyone have any questions for us?
And of course, our contact information is there. For Middle Tennessee, I typically intercept a lot of those referrals, but if I can make sure they get to the right person, if you send me anything, I'll make sure that that we track it and you get what you need. So.
All right. So if nobody has any questions for Youth Villages, they'll stay on and will be available to answer questions throughout our part of the presentation at the end as well. But my name is Kristen Bohannon, and I'm the prevention consultant for the Tennessee Valley region. And after the DCS realignment, I will be covering part of Tennessee Valley and part of the East region. Prior to my role with UT Swartz, I worked for DCS for 12 years in the East region, covering CPS, foster care, facilitation, and I did FSS, FCIP, and resource linkage. So basically everything except for JJ. And I understand how stressful your jobs are, especially now. And that's why we're here to support you and the work that you're doing. We wanted to bring this series of trainings to the front line to highlight some of the evidence-based services that are available. And I know Youth Villages is a provider that probably everyone's familiar with, but if you're like me and you haven't worked in JJ, you may not have known too much about the MST program. So hopefully after today's training, you will have learned something new about MST, about what it is and how it can benefit the work that you're doing in all program areas, because the service is available to youth, even those that are not on JJ probation. So in the rest of the training today, since Youth Villages has discussed their part of the program, my counterpart and I are going to help you connect that to prevention work that CPS, FSS, and FCIP are doing, and how this can be a very effective service to prevent youth from entering custody. We're going to highlight some similarities and some differences in the roles and duties between the DCS frontline professional and the Youth Villages MST service provider. And we're going to do a quick review of how the FAST and CANS assessment is used to develop the permanency plan and what that looks like in relation to a real and current DCS case that has MST services. And finally, we're going to go over the referral process and how DCS frontline professionals can access this prevention service for their clients. And my counterpart, Jill, is going to take it from here.
Hi, everyone. I'm Jill Preston, and I am Kristen's counterpart for the Southwest region. And after the realignment, it will be some of West and Midwest. I was with Southwest DCS for 22 years and did foster care, post-custody, facilitating, and FSS. And like Kristen said, we are here to support the frontline staff. And one of the things we do is conduct trainings on prevention. So we are here today to give some insight into MST. Thank you again, Youth Villages, for helping us better understand the program. Here are some aspects that we want to highlight. The MST is a well-supported, evidence-based program. It's trauma-informed. It's for delinquent or antisocial behaviors for ages 12 to 18, creates long-term positive change, uses the systems theory, is a strength-based approach, builds natural supports, is family and community-based, and is 4-month average time to complete. So let's shift our focus to talk about the roles and responsibilities of CPS, FSS, and FCIP. And of course, they complete a safety or a FAST assessment, complete a permanency plan, refer to needed services, then they maintain contact with family ongoing, as well as ongoing assessments and home visits, and then convene CFTMs as needed. So communication and collaboration are key. So DCS and Youth Villages are both working towards the same goal and often share responsibilities, such as staying focused on the overall picture, immediate needs, and serving the family. It is important to engage in ongoing communication and collaboration with the Youth Villages service professional. Remember, Youth Villages is your partner and you are a team for those at-risk families. MST gives positive outcomes, so improved parenting skills, strengthening parenting and supervision. MST equips caregivers with parenting skills to manage challenging behaviors, reducing the likelihood of CPS. Parents are taught to establish consistent rules, expectations, and consequences to improve family stability. It does improve family relationships and family support. Targeting root causes of family crisis, MST works directly with parents and caregivers to strengthen family functioning, which is crucial for preventing removal due to neglect or behavioral issues. It addresses substance use, mental health issues, and family conflict, all of which are key drivers of child welfare involvement. Youth is successful at school and work and has positive peers and activities. So community school engagement. MST connects families to school-based support and community resources, ensuring the child stays engaged in a positive, structured environment. It improves school attendance, reduces suspensions, and decreases delinquent peer influence. And improved mental health for long-term family stability. The intervention lasts 3 to 5 months, ensuring that behavioral and systematic changes are sustained long after the program ends. It teaches families how to navigate future challenges on their own. So next, Kristen will go over a case study. Kristen?
All right. Thank you, Jill. So I'm going to share a case study example from a real case that's been referred to MST services. And we're going to walk through the assessment, case planning, and outcome of this case. And we're going to discuss a few other examples or see if the audience has any examples of cases that you feel might be appropriate for MST. So when I'm going over the case study, just make sure you pay attention because I am going to ask you to identify the needs that this family has a little bit later. So in this case, the mother had reported that this youth struggles with authority, and most of his problems at home didn't start until he began having behavior problems and getting in trouble at school. So the mother reported that the youth has had services in the past with Health Connect, and those services did not meet his needs. And she reported that his verbal and physical aggression is a lot when he gets angry and upset, and it's usually immediate. She reported that the youth has a lack of respect for women in general, and most of his issues stem from him being away from his father, who resides in another state. So this mom and her 2 children moved to Tennessee from California a few years ago. The youth reports that he has strong feelings regarding his mother, that they do not get along at all, and reported that he struggles with being told what to do. He's failed a drug screen for THC at the initial visit, and he admitted to using a dab pen. And he said that he's both verbally and physically aggressive when he gets angry. He described yelling, cussing, punching walls, slamming doors when he's upset. And he reported that his peers engage in fighting and vaping, and he seems to allow these negative peer influences to influence his behavior from time to time. He has recently been involved with juvenile court on a petition for violation of probation and disorderly conduct, and had been on county probation for previous charges. So one of the first things that you'll do after meeting with a family and reviewing your referral and family history is to complete your assessment. And completing the quality FAST CANs is an excellent way to ensure that MST services are tailored to the family's specific needs. It helps youth villages understand the families that we're working with and what their current needs are. And if you share your assessments with youth villages, then they'll have a global assessment available as a starting point that they can base their services on. Completing the FAST CANs with the family ensures that they are a part of the assessment process, that their voices are heard, and it helps them to see how youth villages can help them meet their needs. So this assessment process is your first step in creating a quality NCPP, as the action steps will address those will be addressed in a permanency plan. So the effectiveness of the services that you're requesting are directly tied to the quality of the information that we're sharing. And DCS plays a crucial role in ensuring that we have all the necessary information to initiate interventions with the family. So as we begin our work, it's important to emphasize that communication and collaboration between DCS and youth villages is an ongoing process to ensure that we're all working toward the same goal. So feel free to come off mute or enter in the chat the needs that you identified for this family and youth when I was going over that case study. I'm not sure if anybody's put anything in the chat because I don't see. It says I left the chat. So if anybody sees anything in there, you want to let me know.
There's concerns of respect and aggressive behavior towards mother, lack of respect.
Okay, awesome. Thank you. I don't know why, but it says I left the chat and I'm not seeing any of that. Okay. So,
and father not being involved, drug use.
Yes. So here are the needs that were rated for this child in the actual case. So these are examples of needs that you could rate in your FAST CANs as actionable, including those that you all have mentioned. So these are the actual justifications taken from the assessment and the case study, and these are great examples of how to write a justification on a FAST CANs assessment because they provide so much detail and a very clear picture of the needs and behaviors. So for discipline, they had that the parent reported that as a form of discipline, she's attempting to ground the youth from going anywhere, makes him do extra chores, and takes his gaming system from him. And she reported that the previous methods of discipline have not been very effective. More often than not, when she tries to do these things, it results in the youth engaging in outbursts that turn to severe physical or verbal aggression. And the parent reported that recently she had just been picking and choosing when to say something because she's afraid of setting him off. For knowledge of child and family needs, we have that the parent reported that she's aware of the youth's strengths and needs and that she's aware of what he needs to do in order to remain in the home. However, parent does appear to struggle with why he behaves the way that he does and how to appropriately respond to those behaviors. And then for family functioning or family conflict or relationship with primary caregiver, we have that the youth has a relatively stable relationship with his mother as opposed to his father, as was pointed out, who's not in the picture currently. But he reports that things with his mother is only good sometimes. So the youth reported that his mother makes his life miserable and that he hates her. He wishes he didn't have to live with her, and he plans to move out when he turns 18. He reported that his mother yells at him a lot and says things like she wishes she never had him. And the mother reported that most of their arguments are because the youth won't get off his gaming system. And the youth says it could also be related to him not doing something when he is asked. Substance use, he's reported that he has no substance use history, but he did fail a drug screen for THC and later admitted to using a vape. For legal or delinquent behaviors or high-risk behaviors, he was on state probation after pleading guilty to disorderly conduct in violation of probation. He had previously been on county probation. It had a disorderly conduct and simple assault charge. He violated that after receiving a new charge for disorderly conduct, and he was court ordered to pay court costs, have no new school discipline, no failed drug screens, and complete the remaining 60 hours of his community service. For education or school behaviors, the youth appears to have a lot of behaviors at school. He's set off at school, he cusses his teachers, refuses to follow directions. That's led to him having the negative behaviors, being sent to in-school suspension. He was charged with threats of mass violence after threatening to shoot up a school when he was angry with a teacher. And then that charge was pled down to a simple assault. And for mental health and anger control, the youth reported that he can be both physically and verbally aggressive. When he gets angry, he yells, cusses, punches walls, slams doors. He did report he likes to take long walks, separate himself to calm down, and reported that he doesn't believe he's ever blacked out from an outburst, but his parent reported that there's been a few times that he's gotten very angry and afterwards he doesn't remember something that had happened. So now that we talked about identifying this family's needs and what the quality assessment looks like, and we will take this over and apply it to a non-custodial PERM plan. So typically you'll do your assessment, meet with the family, develop the permanency plan together. And in this case, pretty much all those needs that we identified could be addressed by a single service, which is MST. So shown here are examples of some of the action steps that could be on a permanency plan. I did not highlight the typical, of course, there's going to be steps for the child to comply with the rules of probation and for court orders, to comply with services, to stay drug-free, all of those things. And then there will be steps for the parent to ensure the youth's compliance and maintain appropriate supervision. But I wanted to highlight some of the steps on this permanency plan that were specifically for the MST provider and for the DCS professional, because I think that might help further clarify how each person's working with the family to help them be successful. So On this permanency plan, the frontline professional had put that the service provider will assist the youth with and the parent in learning how to identify positive and negative peers. The provider will assist the family in identifying positive extracurricular activities that the youth can participate in and conduct safety assessments during each contact with the family. And then they would notify DCS after making a safety plan of any safety concerns. The service provider will create a treatment plan with the family that includes goals on how to maintain permanency, and then provide a copy to DCS and as well as monthly updates. And the service provider will maintain contact with the youth school, maintain accurate records of progress or any issues that need to be addressed, and could also help the youth find employment. Steps for the DCS frontline professional may look something like this: that DCS will conduct safety assessments during each contact with the family, administer drug screens as necessary, ensure that the youth is in compliance with any court orders, monitor the youth's academic progress by reviewing the grades and attendance and discipline records, and assist the youth or family with any other concerns. They can also help identify positive and negative peers and can help assess the youth's free time to help them become part of more positive pro-social activities. And DCS will conduct the home visits with the family to monitor progress. So as you see, DCS and youth villages each have a lot of similar tasks and then tasks that are unique to their specific roles when working with the family. So some of the specific interventions that MST provider was doing with the youth in this case study included conducting mood scaling with the youth, assessing youth strengths and needs, reviewing the drivers of behaviors, and completing assessments for aggression and substance use, and working on understanding what sets the youth off to gain a better idea of triggers. All right, so the client from the case study has been successful with MST services, and he's remained in the home with his mother and is projected to discharge in the next week or so. This is what the DCS frontline professional had to say about the youth and the services. She said, from what I've seen, he has been able to actively work on his anger response to stressful situations. The MST provider's done well with helping the youth find appropriate coping skills to assist him in these times. While the youth has verbalized that he is only cooperating because he has to, he does enjoy working with his MST provider, whose name is Scott. The youth has shown massive amounts of improvement in regards to behavior and his attitude since working with Scott. And this frontline professional said that she had another kiddo that she just released from services. And in that case, the MST provider was really able to help the family navigate their dynamics with each other. She offered solutions for bonding, included the kid's biofather in the sessions. And I believe that biofather was not in the home, but she was making sure to include him. And they worked on appropriate communication with the family. And overall, she said that she enjoys working with the MST team and thinks that for a lot of kids, the service is very helpful. So we really appreciate her feedback and her allowing us to use her case as our case study to show the benefits of using MST services with our families. I do want to highlight that MST is not just for JJ youth. This was a JJ case, but any frontline professional that is working with a youth with antisocial or delinquent behaviors can access this service to maintain the youth in the home and with their family. So next, Jill is going to go over a couple other examples of cases that may be appropriate.
Okay, so after walking through that case study, we thought that we would discuss some other examples of cases that could potentially be referred to the program. So if anybody has had any cases that they would like to share with the MST program, just feel free to come off mute or put that in the chat. We have a couple of examples besides that, though. So the first one is a FCIP case involving a 12-year-old youth with charges of theft and assaulting his grandmother. Charges have not been adjudicated. Issues with grandmother providing appropriate supervision and discipline in youth is destructive and aggressive. So in the chat, or like I said, come off mute, why would this case be appropriate for MST? Why would somebody put in a referral? Yes, we got delinquent charges. So first, the age is correct. It's a 12-year-old youth. We have charges of theft and assaulting his grandmother. So we have delinquent behavior, at-risk behavior, and court involvement. Charges have not been adjudicated. And then we also have issues with grandmother, appropriate supervision and discipline. And then, of course, at-risk behavior with youth is destructive and aggressive. And another example would be an FSS case involving a 15-year-old who is associating with gangs. Youth was a witness and a possible participant in a fight at a local football game. And youth is on county probation for possession of marijuana or vape. So what would make this case also a good fit for MST? Why would you refer for this? So once again, 15-year-old, that would be an appropriate age. We have at-risk delinquent behavior associating with a gang, and youth was a witness and possible participant in a fight at a local gang, and then court involvement. So we have county probation for drug use. Okay, so finally, we're going to discuss the referral process, and there are two main funding sources for MST services, and that is TennCare and FFPSA for e-funding. So please note that private insurance is not accepted. For TennCare funding, youth must have a mental health diagnosis. It must have previous treatment. So you complete the Youth Village's referral form and send it to your regional Youth Village's contact. And then they will let you know when they can meet with the family and about insurance approval, timeframes, and estimated service start date. So here's your Youth Village's regional contacts. You send them this for the TennCare funded MST referrals. So then please note that South Central and Upper Cumberland, you send those to Laura Cook.
Jill, we have a question in the chat. The question is, can you give us an example of antisocial behavior?
Well, the thing that comes to mind is like staying in your room, like a teenager, not wanting to socialize, just, you know, just staying in the room, not wanting to hang out with anybody.
Yeah, and just some of the things that are also delinquent behaviors, maybe even if they've not been charged, but getting into fights, having those anger issues, just pretty much any of the drug use, things like that.
Okay. And if the youth does not have TennCare or TennCare cannot be approved, then you can complete these steps for the funding through FFPSA prevention funds. And so you complete the FAST or CANS, CFTM, and the permanency plan and TFAX, make sure it's approved. And then you're going to send an email request to the DCS FFPSA coordinator for your region, and we'll show that next. They're going to verify candidacy, and if eligible, then they'll do a case service request. And the DCS case does have to stay open during the MST services. This is the template for information needed when you submit your email request for the funding, for refunding. And right now it's going to them in those current regions, but then after realignment, it will be that. Okay, so we are at the end of our training. This is our contact information for my counterparts across the state. So please reach out to us whenever you need assistance with a FAST, a case consult, prevention education, services, resources. We're here to help you. So thank you so much for joining us. Does anybody have any questions before Kristen does our last slide?
Okay. Are there any questions in the chat? Okay.
There's not.
Okay. So like Jill said, thank you everyone for joining us today. And I just wanted to share the next training that we're offering is Parents as Teachers. That's coming March 6th. And you can scan this QR code to visit our website where you can get our contact info that Jill shared on the previous screen and also see all of our previous trainings. Any that you've missed, they are posted there. And there's flyers for our upcoming trainings as well.